Welcome to the France 24 debate. In spite of what some politicians worldwide would like us to think and what they're saying, the COVID pandemic is not over. In fact, another widespread problem is following it. Long COVID is the persistence of the symptoms beyond the initial infection. In some cases, this can last for months, even longer. It can seriously debilitate the person concerned. There are 2 million long COVID patients in France. The World Health Organization says there are some 145 million worldwide. Yeah, the French government's scientific group, COVARS, as it's called, in its research, has concluded that it's a psychosomatic problem, basically telling the sufferers that it's all in their head. Our panel to discuss the long COVID question. In London, Professor Danny Altman, immunologist, co-author of the Long COVID Handbook. Professor Altman, thank you very much for being with us.
Pleasure.
Joining us from New York, Sarah Gorman, PhD in public health, CEO of Critica, a group that promotes informed health decision-making, author of Denying to the Grave, Why We Ignore the Science That Will Save Us, and Modern Medicine, Conspiracy Theories and Distrust in 21st Century America. Thank you, Sarah, for being with us.
My pleasure.
Here in the studio, Jan Cedric Hansen, who's Vice President of the Global Health Security Alliance. Jan Cedric, thanks for joining us. And on the other side of our studio, Emma James, France 24 journalist, currently not working because of, yes, long COVID. Emma, I'm going to start with you in a second. I have to say right now that we approached COVARS for an interview and offered them a place here in the studio, but none of the 18-member panel was available to join us. So let's start with you, Emma. Currently suffering with long COVID. How's your day been so far?
Interesting. It is one of those things. I had actually been feeling a little bit better the last couple of weeks, and you start to think maybe I can make a return to work. But then the activity, the certain element of stress of getting ready to come in here today, I arrived and I thought there is no way that I could come in and do a full shift. Now, I know that I will pay for what I'm doing here today because that kind of exertion of simply coming in here, even though I came in a taxi and sitting here talking for an hour, I know that it's going to take it out of me. And that might mean that I feel like I'm coming down with flu again tomorrow or feel like the early symptoms of COVID, but it doesn't develop into anything. And I will probably feel very tired over the next couple of days.
Okay, because full disclosure here, because I should tell everybody and share with the panel that I know about Emma's symptoms because she's my better half. And I've witnessed how since she first caught COVID back in 2020 in March with the first wave, how basically her life has been changed beyond, well, you don't have the same life as you had before.
Not at all. No, I mean, my life has shrunk from being able to do anything that I wanted to do. Basically, I now have to make choices all the time as to what I'm going to prioritise. In the early days, for a long time, I had to choose, do I have a shower or do I walk around the block with the dog, because I couldn't do both. And it is incredibly debilitating and really quite depressing too, because suddenly you go from being able to walk in the forest for 4 hours. We live in a beautiful part of France. There are many, many hectares of forest, which we have investigated over the years. We've gone on holiday in the Alps and walked all day. Now I've built up to the stage where I can maybe do an hour's walk, but usually that's quite tough. Some days I can only walk for 10 minutes, and it really is a huge change. And obviously I'm no longer working because it's simply not feasible.
Indeed. So many more symptoms beyond, but of course you'll tell us more about that as we go along. Let's bring in our panel to talk more about this issue. First calling on in London, Professor Danny Altman, immunologist, but also co-author of this book, the Long COVID Handbook, which is required reading in our house right now. Professor Altman, thank you for your book. Thank you for joining us here on France 24. Can I start by asking you, sir, what you feel about what the scientific advisors to the French government are saying, that this is in the heads of people who have it?
It's a very difficult question to ask me because throughout the pandemic, I've tried never to take on policymakers and never to move outside my lane as a scientist. But I wish they had come on to discuss, because please let me say, when I listen to Emma's story, it's a very common story for me to hear, yeah, because we're running a long COVID study in our clinic in the hospital, and I sometimes pop down to meet people taking part in our study. And these are people like her. They're people who were formerly busy, active people, marathon runners, cyclists, mountain climbers, who now feel like their lives are destroyed, like they're disabled, sometimes they're bedbound. And that's something which is measurable. It's measurable in their oxygen transfer. It's measurable in the antibodies in their blood. It's measurable in their breathlessness. This couldn't be further from psychosomatic. So I wish they had come on to have a discussion about it.
Indeed, I think we all wish that would have been the case. Professor Altman, I'll get back to you very shortly. Let's go to New York. Sarah Gorman, a PhD in public health, CEO of Critica, author of books on health. Sarah, thanks for being with us. We appreciate your time. Can I ask you the same question? What's your reaction to this finding, I'll call it that in inverted commas, from the scientific people here in France?
Thank you for that question. I think that the idea of psychosomatic illnesses is a bit outdated when we really think about it, because we know so much about the ways that the brain and the body are so interconnected, that mental illnesses are physical illnesses can be in the brain. And I think part of the issue with long COVID is that there are some brain-oriented symptoms that are very common, like brain fog and fatigue, and even depression and anxiety. But that doesn't mean that people are, quote unquote, making this up. As the professor just said, there are markers of this illness, and we see 20 to 30% of people experiencing these symptoms after they recover from COVID. And so just the fact that there's a brain involvement in many cases does not, in any case, especially if it's a psychological symptom, mean that it's not also a physical illness. So I think we should really just do away with that term, in my opinion.
Sarah, for now, thank you very much indeed. Get back to you very, very shortly. Jan Cedric Hansen of the Global Health Security Alliance, thank you for being with us. And I'll point out again that we wanted to get the people who came out with this finding and published it to come in and talk about it, but they couldn't make it. And you're not here representing them, Jan Cedric. You're here representing your own group. What are your views on what they've said?
Well, first, I would like to explain a bit about the COVID disease, because and what you explain is exactly what I experience with my patients in every day. And that it is a betrayal of the body. And to find that you were healthy, you had something that was not that difficult. Some fever, some headaches, some shivering, things like that. And all of a sudden, your body is betraying you. And what is really annoying is that it may last longer than weeks and months sometimes. And I have patients who have been suffering for months and ultimately die of that. So it is a very concerning matter for me. And what I want to explain is that the COVID is an inflammatory disease. It actually activates dramatically your inflammatory system in your body. We have a complex system in our body that is there to balance any inflammatory occurrence in our body. And when you have suffered, not everybody, but many people who have undergone COVID disease have a totally unstable inflammatory system inside their body. And that explains fatigue, dizziness, joint pain. And some people will express it through their joints, others from their bladder, others from their lungs, chest, heart, brain, whatever.
And there's no way of predicting how this will turn out?
Well, not yet.
Not yet, anyway.
Maybe one day, I don't know for sure. But so the betrayal of the body will lead to a, you may call it psychosomatic, but it's not psychosomatic. It's a psychological response to the betrayal. It's almost like a post-traumatic syndrome, because you don't understand why you can't do what you used to do before. And there's no reason to explain that. So that's the fatigue syndrome is coming from this huge inflammatory level inside your body. And we have many biological samples that actually demonstrate that there is a high level of inflammation inside the bodies of the patients who are suffering that. So mentioning that it is purely psychosomatic is really something surprising from my side and from my medical experience. But maybe our friends have comments on that.
There will be much more discussed in a moment's time. Let's basically show you all now something that we filmed about a year ago here at France 24 with a doctor leading research and trying to help people with long COVID. Let's take a look at the work that she was doing then.
Life-changing health conditions which affect children and teenagers too. In February 2020, the Peters family all caught COVID-19. They still haven't recovered.
Maëlie lost 17 kilos and was in hospital for nearly 3 months. For Manoa, the most disabling symptoms are his hypersomnia and brain fog. I suffer from effort-induced fatigue and faintness.
Avant, oui, j'étais jamais malade. Je suis très peu de fois allée voir le médecin parce que je n'avais pas vraiment besoin. J'étais celle avec la meilleure santé de la famille.
To preserve her strength, doctors have recommended the 18-year-old shouldn't leave the house to go for a walk.
Comment tu te sens, ça va?
Oui, ça va.
T'es pas trop fatiguée?
Là, non.
Non, ça va pour l'instant. We used to do a lot of sport together, every weekend. Cycling, hiking in the mountains. We were really a sporty family. Physical activity was very important for us. Now we go for walks, but never for long ones, 10 to 15 minutes, and we can't go every day. That's about all we can do.
Je suis vite essoufflée. Et la fatigue, ça dure sur plusieurs jours, voire semaines.
Tu dors toute la journée.
J'ai peur de ne pas pouvoir reprendre la vie comme avant.
For 14 months, I wasn't able to look after the house or make meals. If I tried to prepare something to eat, I would get tired after 15 minutes and have to lie down for half an hour. Then I'd try again for another 15 minutes. The children had to help me a lot.
Over the last year, Manoa has been in school on and off, alternating between part-time lessons and full-time rest at home. Today, his English teacher has come to the house.
What time do you wake up in the morning? What time did you wake up in the morning?
I wake up
At what time? 7, 8, 9?
12. Dans la concentration, là, ça allait. Mais si on fait jour après jour sans repos, bah là je vais avoir moins de concentration.
Difficulty concentrating, known as brain fog, is a common symptom for long COVID sufferers. Manoa sometimes sleeps for 20 hours a day.
Par exemple, en maths, j'ai plus de mal à visualiser dans ma tête pour les calculs. Je suis plus obligée de compter sur mes doigts.
What do you miss most?
Les amis.
Je suis vraiment pas en capacité de travailler.
I'm not able to work. It's something that really worries me.
Donc,
I'm on my own with my kids. It's very worrying, not knowing how we'll pay the bills in 6 months' time.
Les factures ou comment ça va se passer.
Not being taken seriously has added to Karin's stress.
Il y a encore beaucoup de médecins.
There are still lots of doctors who think it's all in the head. I feel angry that I haven't been listened to. Things are changing for adults, but not for children.
Pour les enfants, pas du tout. Et souvent, on apprend aux médecins, en fait.
We're often the ones who inform doctors about the latest studies. We provide them with documents and links.
Vers certaines études et
That's another reason why we feel abandoned, because we're better informed than some doctors are.
que les médecins.
After several months without being diagnosed, it was the Professor Salman Seren who confirmed that Karin has long COVID. She runs one of the few specialized clinics in France.
A lot of my colleagues didn't believe in long COVID. They thought we were inventing an illness. They thought long COVID was like all post-infection chronic fatigue syndromes. Now we've shown that in a significant number of cases, the virus persists.
Claire Pacquelin, our reporter there. Emma, can I bring you back in? What kind of help have you had? How would you describe the kind of help that the system's given you here in France?
It's interesting because you were talking earlier about a betrayal of the body when it comes to COVID. And I think for a lot of people with long COVID, there is a feeling of betrayal by the medical fraternity. And I know from my own experiences, while I understand why it is very difficult when somebody comes in with a shopping list of symptoms and their test results come back as normal, I can understand why ordinary GPs, family doctors might not recognise that there really genuinely is a problem and you just have to dig deeper. The specialists, of course, are getting there with these ideas of how you spot the problems, the things that are flagged up, the markers in the body, the markers in the blood and the like. But the doctors that people see day to day aren't there yet. So far, I've been given vitamin D and told that it might help me to go and have a spa break in the Alps, which I'm sure would be lovely. But I don't think that's going to actually solve my problems. And when they do find something that is an anomaly, they're very quick to explain it away. Even some of the specialists that I've seen, I saw a cardiologist recently, and she talked about, oh yes, your heart rate is very high, but we have been chatting. Now, my heart rate should not be that high from chatting. It's not normal. And I know, I can feel it almost beating out of my chest sometimes, that it speeds up so much, and it's not normal for the amount of effort that I'm putting in at that time. I had a lung specialist tell me after getting me to blow into a tube while sitting down, your lungs work perfectly normally, go away and live your life. Now, if you're not tested fully and under stress and all that sort of thing, how can they possibly tell you that you're fine? But what they see is that the normal tests come back as normal, and they say you are normal, and if you think you're not, then it's just all in your head.
Emma, thank you. Let's go back to London. Professor Danny Altman there, the immunologist, author of the Long COVID Handbook. Professor Altman, listen to what Emma said, and obviously with your own insight, which is wide-ranging and deep. Is the medical profession adapting to this new challenge? Is the medical profession finding ways of treating and ways of trying to diagnose things?
Well, there's an immense amount of research in many countries, and varying amounts of understanding and goodwill. I'm very disturbed to hear the stories I've heard the last few minutes of gaslighting and ignoring people's physiological illness. Perhaps it would be helpful to spend 2 minutes paint a picture of what's gone on in the UK. The picture I would paint is that we prided ourselves here, I think, on having been ahead of the curve. So there was an early acknowledgement that long COVID was a thing, and because we had good statistics, that it was a relatively common thing. We have the ONS here reporting every month. Today we heard that long COVID is on a plateau, a very high plateau, of about 2.1 million cases, so about more than 3% of the population. So the government and the NHS put in place long COVID clinics with the idea that anybody with these symptoms could be referred to one. And that sounds good, doesn't it? And that's been variably successful. It depends where you live, how long the waiting list is. But getting there isn't good enough, is it? Because once you get there, you need some trained staff who have some guidelines and have some clue what to do for you. And as we've been hearing, there are no tests yet that can prove that you have long COVID. So depending on how gifted the doctor is, they might recognize they need to send you to a cardiologist or a neurologist or a rheumatologist. But you can see where I'm headed with this, that just having the badge above the clinic isn't sufficient. What we have is a new health burden as large again as the whole of rheumatology or the whole of cardiology, that I think will require specialist centres where you have all of these medical specialists in the same department at the same time to really have the wherewithal and the tests and the equipment to send the patient away with some hope, feeling better than when they came in. And in the UK and everywhere else that I know of, we're still a long way off from that.
Professor Altman, thank you for now. Let's go to New York. Sarah Gorman, PhD in public health. Can I tack you on this one, Sarah? We've heard from Professor Altman about the situation in the UK. What's the long COVID situation like in the US? Can you give us a bit of an insight on that, please?
Sure. So I think we've also had the experience of getting some good funding from the National Institutes of Health to study long COVID. But I think what we're still lacking is really two major things. One is training medical professionals about how to communicate in the face of immense uncertainty. I think medical professionals are still not really seasoned in doing that. And it creates a situation where they can be dismissive because they don't know how to talk to patients about the fact that we still don't know everything that we need to know about long COVID. I think there's an opportunity for more coordinated care, which is also difficult in the US and in our current healthcare system, that could help show insights about the illness itself, but also make it so that patients' symptoms are being treated, even if we can't cure the disease. And then I also think that there needs to be some more oversight and attention to some of the misinformation that's targeting long COVID patients on the internet and social media. That's been a huge problem. It can be very politicized in the US, and I think that needs to be overseen and dealt with as well.
Sarah, are people taken seriously in the US when they say they got long COVID?
It depends. It really depends on the individual physician and who's treating them. I think there's a lot of dismissal happening and a lot of, doctors just getting frustrated because they don't really know. There isn't a clear guideline or protocol for them to know what should they do, how should they thoroughly evaluate the patient. And there needs to be more discussion of what do you do when there isn't a clear sort of test or marker or treatment for a significant illness that's affecting a lot of people.
Sarah, thank you for now. Let's bring in Jan-Cedric Hansen of the Global Health Security Alliance. We heard there from the UK, from the US, about how things are viewed there, obviously from your perspective. Are you hearing anything different from what you've found?
No. What I would like to add is that we definitely need to clarify what means long COVID. Right now, it's a bundle. With many clinical situations that are mixed together, and we have hard time to recognize whether it is what we call a syndrome, so a list of symptoms that match together and that are directly elicited by the COVID itself, or is it diseases that were silent up to now and which have been triggered by the COVID infection. And just this question, simple question, would clarify this bundle so far. And the second thing is every specialty is looking at it on its own angle, and there's a lack of a holistic approach of that bundle. And I think if we do what we call the taxonomy of those numerous situations that are coming to us from our patients. And I think that the centers in the that have been created by NHS is a good start for that, is to identify what are the different situations. Can we group some patients? Are they all different? What are the common points? Maybe common mark in the blood or whatever, as you mentioned. And then it is a research work to be performed that has not been performed yet. And to be interested, we should get very interested in about why do the patient die from COVID. Investigate them properly in a scientific manner, in evidence-based manner. And in doing so, we might discover things. Our perception at the Global Health Security Alliance is that the COVID pandemic is going to dramatically change the state of health of the entire world population. And it might change the proportion of inflammatory diseases. We are not looking through a crystal ball by saying that. It is a potential issue. We are not saying this will necessarily happen, but we should monitor that definitely.
Indeed. Thank you, Jan-Cedric. Coming back to you, Emma. Mm-hmm. You are as capable, if not more capable than I am, of hosting this show.
Obviously.
You are an excellent live broadcaster, but right now you can't do your job. Is that about brain fog? Tell us about brain fog.
It's a mixture of things. It is the level of fatigue that I suffer if I do too much. That is a big part of why I'm not back at work. But it is also, and brain fog seems to have been something that has crept in more and more. I'm now approaching 1,000 days post-COVID. I got sick on the 5th of March 2020. On the 29th of November, it's going to be 1,000 days of this. And in the last year, I would say, my cognitive abilities have been so clearly damaged. And it's really changed a lot. There was a lot of forgetting words in the early days, but it wasn't too bad. Then it seemed to graduate into just, I would read something and instantly forget it. You spoke to me the other morning and it was like you were speaking a language that I'd never heard, because I had to keep asking you to repeat it because I heard it, but I couldn't make sense of what those words are. Now, that is not normal. A brain fog sounds quite mild, and what people tend to say a lot, which is very annoying, is that, oh, everyone gets confused from time to time, everyone forgets words, and I know that doctors I've seen have said, yes, but is that in French that you're forgetting the words, or is it in English? And they're assuming that it is a question of, it's just her language skills letting her down. It isn't. It is a question of something goes. It's almost like someone's gone in with an eraser in the night and just removed something that I know and have known for years, and suddenly it's gone. It can be when I'm driving, I forget where I was going, or I get to where I was going, and I suddenly think, am I in the right place? And it's very disturbing, and it really does put a great deal of difficulty into your everyday tasks when you don't quite know when your brain's going to really let you down.
Emma, thank you very much indeed. Stay with us. Well, obviously, we're leaning on you for more insight as to what you're going through. Let's go back to London to Professor Altman, whose book is, as I say, some staple reading in our house, and it's very useful. Professor Altman, have you got any words of hope, any sense of how this can be attacked? Is there something people could do for themselves? Because perhaps they're still waiting for the medical profession to kick in and bring them solutions.
Well, let me say some hopeful things, but maybe some pessimistic things as well. So on the one hand, let's move completely away from any psychologizing of this or gaslighting of this. This is a physiological, immunopathological consequence of having SARS-CoV-2 virus on board. So the situation Emma's describing of being a long COVID sufferer more than 2 years down the line is identical to 500,000 people in the UK. And those aren't people who just, feel like having a duvet day and watching Netflix. Those are people who have physiological changes on MRI in the COVARS trial, on xenon gas exchange in the Explain Oxford study. These are physiological studies that anybody who would like to on the COVARS panel can look up on PubMed and can read the evidence, with their own assessment and their own judgment. So this is a real thing. It's a real thing that's being very extensively studied. So my optimism, to start with the good news, comes from the point that I am an immunologist, and immunology has been a very successful field in the last few decades. If you look at what's been achieved in cancer immunotherapy, in autoimmune diseases like multiple sclerosis and type 1 diabetes. So I think that once we have the mechanisms, which will be soon, we have a shelf of goodies to resolve those symptoms and deal with it. Okay, so that's my good news. If you give me a half a second for the bad news.
Go ahead, sir.
And the good news is very good, yeah. Just emphasizing what a real thing this is and what an enormous thing this is. I tried to do crystal ball gazing to guess where we were headed and how long this was going to last. And I approached the professor of medicine in Toronto who had dealt with the SARS patients in 2003, 2004 in his clinic. And I said, give me a vision of the future. How long did it take them to get better from their long SARS, which essentially is the same thing? And he wrote me an article that was so terrifying, I hardly dared publish it. It said, when I look back on my patients, none of them got their lives back. None of them got their jobs back. None of them were ever the same again. So if you like, that's the incentive for us to try and do better this time around.
Danny, thank you very much indeed. You're right. The pessimistic bit was very pessimistic, but I think the optimistic bit was clearly very much that. And let's hope that that sun comes to shine on everybody who is suffering. Let's bring Sarah Gorman back in from New York, PhD in public health, CEO of Critica, group promoting informed health decision making. Sarah, I don't know whether this is a question for you, but I'm going to throw it out there because I'm sure somebody can have a good opinion on it, and I'm sure you will too. Emma had COVID-19. We lived together. I didn't catch anything. As far as I know, I've never tested positive for COVID-19 at all. Why do some people get it and some people don't? Why do some people get long COVID, some people don't? Well, is there any factor that an average person can see?
Some of this is still very mysterious. And what I did want to say is that there's a lot we still don't know about COVID, let alone long COVID. So that's very important to remember. We're learning more, and hopefully that's part of the optimism here. I would say in terms of why some people get COVID and some people don't, some of it has to do with there are people who have sort of, it's not many people, but there are people who have sort of mutations where they can resist the virus and they're kind of they are able to dodge the virus over time. But other times it's just random. You can be exposed to the virus certainly and not get it. It has to be in the right place at the right time for the right amount of time for you to get it. And I think in terms of long COVID, it's another thing we're not really sure what predisposes. At first, I think some people thought maybe it was for people who had more severe cases of COVID, but that turns out not to be the case. But I do think that as more people from more walks of life with different levels of severity of their initial infection get long COVID, that there will hopefully be more pressure to really figure out what's going on here, what we can do about it, and how much the medical profession needs to take it seriously as well.
Because this was something that caught everybody by surprise. And I think, I think people in general, Sarah, can give doctors a break in that sense and think, yes, everyone was taken by surprise. So you were managing an emergency. But so much further down the line now, and with people long-term affected, as we're seeing, there is a real pressure now to find some solutions.
Absolutely. And I think one thing I will say that's a little pessimistic is that we do find things out about viruses very later on, like a recent discovery that measles really can affect your immune system long term. So viruses can have long-term effects, and we don't always know for many, many years. So that could still happen with COVID. But I think it's what I said before, this idea of, because there will be more pandemics and new pathogens, we need to train the medical profession about how to communicate with when there's a lot of uncertainty and how to still take things seriously when you don't know the answer.
Indeed, communication, very much the key. And I think that's probably something, Emma, that I know you've experienced it. I'm trying to couch it journalistically.
Absolutely.
I know you've experienced
Yes.
that. Yeah.
Yes, definitely. And I think it's interesting that you talk about the medical profession being taken by surprise with this. But what's interesting is that as the months have gone on with COVID and more people are saying, hey, my symptoms look just like ME or chronic fatigue syndrome, it really has highlighted how not enough has been done to get answers on that. There's still no treatment for ME or chronic fatigue syndrome, whichever you choose to call it. And a lot of lessons perhaps could and should have been learnt in the decades that that's been around, because there are a lot of similarities. And interestingly, the first person to mention to me that, hey, this sounds just like ME is somebody who has ME, who I know via Twitter. And social media has really been one of the most invaluable resources during this pandemic. And basically, sort of groups of people have found one another and are sharing information. And some of them are doctors, some of them are pharmacists. And there's a wealth of information out there. Yes, you have to be careful about who to trust. But the thing that I have noted is the only things that have helped me at any time during all of this were things that I learnt about via social media, not from medical professionals. And I do find that really disturbing.
Okay, so a positive thing about social media, Sarah earlier spoke about the negative things that come out of social media, and that's the nature of the beast, isn't it, I suppose? Jan Cedric, you wanted to make a point about long COVID triggering things. Explain the point you were trying to make to us earlier.
Well, since the COVID is really an inflammatory disease, and I mean, during the acute phase, you have a storm of inflammatory proteins that invade the body and disrupt many physiological systems. And that's the life-threatening situation when it's too high. It actually seems to trigger long-term inflammatory unbalance in your body. And this is more likely to trigger silent disease that you may have, but that was not yet there because it was waiting for the good time. And the disease find out that diseases are not entities, but they behave like entities, and you may consider them as an entity from a non-scientific side. But it's like a disease is there. You have potentially the ability to develop a specific disease. And if you have a storm of inflammation in your body, then the disease may find its way to express itself and act on its own and become individual an individual inside yourself. That's sometimes what the patient describe, their disease as an individual inside themselves. So
this is incredibly, it's a very dastardly way, incredibly sort of intelligent virus in some of the ways.
Well, you can't say there is intelligence in the virus. I think it's too much.
I'm speaking as a layman, obviously.
Yeah, but a virus has a potential to change the function of your body. And by doing so, it may weaken some part of you or some barriers against some disease that you naturally have, and then change your relationship with the internal disease, external disease, chronic disease, acute disease. And that is, I think, what is going to happen in the coming years. We are going to find out that the relationship we have as a population with the disease, the different disease that exist, will change because of the COVID pandemic. But maybe another pandemic will change the game again. I guess my colleagues agree, or maybe they disagree. I don't know. I'd like to hear from them.
I'm sure. Well, let's go to Professor Altman for the first bite on that one. Do you agree that this has changed the whole definition of how we look at viruses and pandemics?
Oh yes, totally. I think the point I was making earlier, when I talked about a clinical burden as big again as our biggest burdens, cardiology and rheumatology, that's what we're talking about. And there may be, as we've discussed, many manifestations. Some people may be targeted because of their heart problems, because of their lung problems, because of their kidney problems, and they'll end up going down different clinical pathways for their care. But to me, the common denominator is that it's upon them because of the COVID infection that they've had sometime in the last 2 to 3 years. And, I think governments will be forced to take this seriously. They have no choice, because if they don't, it will devastate the health systems in all of our countries, because we're going to need more clinics, more doctors, more care pathways, more health insurance definitions of long COVID disability. It changes everything. And, we can't just stick our heads in the sand. We don't have that choice.
Professor Altman, thank you very much indeed. Back to New York, Sarah Gorman. I'm not trying to get you to make a political statement here, Sarah, but I'm going to put this to you. Joe Biden said the pandemic's over. Would you advise people to keep wearing a mask in crowded areas?
Yes. I don't think the pandemic is over. I think we still need to wear our masks. We still need to take precautions. I think, there are things like the number of times you get COVID is important. The fewer times you can get it, the better your chances for not having long-term effects. So you really need to protect yourself, even when someone says it's over. Of course, we need to live our lives and not, create other risks like not keeping children out of school. But I think it's very important to remember that even if you can't take all the precautions, you should take as many precautions as you can, because even in that harm reduction way, you're still helping yourself and protecting yourself for what can be years of symptoms.
Sarah, thank you. Emma, can I come back to you to ask about exercise? Because I know that you were prescribed physiotherapy at one point, which led to a really serious relapse.
Yes, absolutely. And it's one of the things that you might think that doctors would already have learnt from ME and chronic fatigue syndrome, that there are people who have this post-viral issue with exercise. It's called post-exertional malaise, or it has various different names, but that's one of them. I didn't know too much about it. A year ago, I felt like I was getting a little bit better, so I thought, right, let's see what more we can do. And so my doctor suggested going for some physio to sort of build up my lungs and my lung capacity. And the physio that I went to would be fantastic if you were healthy. She was absolutely brilliant. And initially, I thought it was all going amazingly well, because adrenaline kicks in, you're using your body finally, and I was absolutely loving it. But I was getting progressively more tired with each session, and I ignored all kinds of warning signs. And it was only about 2 months into this physio program that I found myself sitting on the floor, having passed out in the middle of a session, and I still couldn't see. My vision was completely black, and the physio was saying to me, "Come on then, are you ready to get up and go again? Come on." I said, "No, I'm finished, I'm done," because it was taking me longer and longer to get better after each session. And that was the final thing that made me sit up and see sense, metaphorically speaking, because I couldn't see anything at the time. And so after that, I stopped. But then it really kicked in, and it was almost like getting COVID all over again. I didn't have COVID again, but I felt horribly ill, very weak, and I was so much more exhausted. And really, I'm only just about getting back to where I was a year ago now. And it's one of the things that doctors absolutely have to be warning people about, because you see it on social media again and again, people talking about, I've had COVID and I've gone back to work, but I'm still feeling really tired. And they don't understand that that's long COVID, and that exercise or exertion of any kind, it can be mental, it can be emotional, can really have such a knock-on effect on your recovery.
Jan Cedric.
Yeah, well, recovery, that's the key word. It's an old medical term. 30 years ago, if you had a heart attack, you would have 3 months of recovery, resting at home, waiting for your body to handle the shock, the physiological shock of your heart attack. But there were not all the techniques that are available today. So it's another world. But the COVID reminds us that in some specific situations, let's say the living stock in your body, like if you have a vital vial with some vital in you, and anytime you are undergoing some stress, whatever the stress is, you actually partially empty that vial, but you need to restore the level. And when you drain it, you drain large amounts, but when you restore it, it's only little drops of it. So when you got it is just like as if when you get COVID, you actually almost empty completely the vial of vitality in you. And you need many, many months to have the drops to refill it completely. And if you do too much exercise, you actually drain completely your vial and then become exhausted and so weak, as a matter of fact. And this is much like gerontology. In gerontology, when you want to rehab an old person, and frailty old person, you never ask to do more than what he can. And by doing so, you allow that person to refill its vitality vial. Of course, it's not scientific what I'm saying. It's just a way to understand. I'm not.
You're helping me to understand. I think
it's
that
not.
helps
Yeah,
most people
it's
watching,
images.
sure.
So it's more images to understand. Sure. And if you take the time to refill, then you'll have perfect stamina, and you'll be again up to able to do whatever you wanted. And what's going on is, in our world today, we want to be back in the game too early. We need to rest. We need to get recovery. And that is very important.
Some people sadly need to get back in the game because they need to work and earn a living and feed their families, and this is the pressure of modern life, isn't it? I suppose, you know.
That's why we have to redefine health insurance and health recovery, and many aspects, social aspects, are going to be changed by the pandemic in the coming years. We could do that, you know, in a more drastic way if we take care of it and listen to our patients, listen carefully to our patients. If we don't listen to our patients, it will take years to learn from that.
It would have been fantastic to have had someone from the COVARS group, or one of the 18 scientists there, to come in and defend their position. But I think we've had a good discussion here about sort of what this condition is about and how people are suffering. And thanks to you, Jan Cedric Hansen of Global Health Security Alliance. Thank you very much to Sarah Gorman, joining us from New York, PhD in Public Health, CEO of Critica. Thank you, Sarah, very much for your insight. We appreciate it. Thanks to Professor Danny Altman, immunologist and co-author of the Long COVID Handbook. Thank you, sir, very much indeed. Thanks to, well, my wonderful Emma Jane, colleague, partner in life, and obviously, for now, suffering with long COVID, but hopefully some recovery on the horizon. I hope, my dear. Thanks to you all for watching. Stay with us. Stay safe.